Hello and welcome to this session of the GACD Masterclass entitled A Case Study on Applying EPIS to Scale Up, Integrating Non-Communicable Services into Primary Care in Botswana. My name is Tapela. I am an internal medicine physician and epidemiologist with a particular interest in NCD prevention strategies in resource-limited settings, including in sub-Saharan Africa. And I currently am the Chief Scientific Officer for a nonprofit called ICHOM, whose goal is to define and standardize outcomes that matter most to patients. I also maintain affiliation with the Botswana Harvard AIDS Institute and the University of Oxford. Over the last decade, I've worn several hats in the global health and care improvement space, and most relevant of these to the discussion today is as the head of the National Non-Communicable Diseases Program in the Ministry of Health in Botswana, my home country. And really this presentation is a walkthrough, a real-world walkthrough of some of the questions and challenges and the decisions we struggled with my team in trying to implement evidence-based clinical guidelines to prevent and control NCDs in Botswana's context. And we leaned heavily on the EPIS framework, which is hopefully I'll be able to outline how we went about doing this in the next 20 minutes. I also, for some context, have included two pictures here. On the left is the picture-perfect, glistening city, Gaborone, which is the capital city of Botswana. And in fact, the white building there is the Ministry of Health, where my office used to sit. And on the right is a tarmac road that cuts across a village just 70 kilometers west of the capital city. And you can see, it's evident to see in the pictures juxtaposed the difference in investments in those two settings, and arguably the differences in the chances at health for people living in these two settings in the same country. And for me, these two pictures juxtaposed really remind me and us all of the resource limitations that can exist all over the world in high-income countries as well as within developing countries, and hopefully reflect some of the challenges that we had to confront in terms of scaling and implementing evidence-based practice across different contexts within one country. So what I hope you'll get over the next 20 minutes or so is to gain some insights on the barriers that we had to address and consider in this implementation, and also to outline what strategies we used to address them, really, again, heavily using and guided by the EPIS framework. I'll also mention as we go along some of the global targets and relevant resources by the World Health Organization that might be relevant to you if you happen to be participating in similar efforts in other contexts. So this is a heat map of the probability of dying early from NCDs in 2016. By NCDs, I'm referring to the major four, so cancers, diabetes, cardiovascular diseases, and chronic respiratory disease. And dying early, meaning dying between the ages of 30 and 70, which is WHO's definition of premature death to NCDs. And the green means lower probability of dying, while the red and the deep red means higher probability of dying, exceeding 30%. And what you can see is that the reds are all over, but they tend to concentrate around developing regions of the world. And in fact, 85% of the premature deaths due to non-communicable diseases are happening in low and middle income countries. So it's really in this context of a concerning burden of non-communicable diseases, and that's disproportionately affecting parts of the world that are less resourced, that global targets have been set. And most notable of these is a Sustainable Development Goal 3.4, which stipulates a goal of reducing by 1/3 premature mortality from NCDs by the year 2030. And achieving this target really requires both preventative and treatment approaches to non-communicable diseases. And to this end, WHO has put out a couple of tools to help countries and actors to be able to tackle this and achieve this target. Of note is the WHO-PEN guidelines, PEN standing for Package of Essential Non-Communicable Diseases guidelines, which really describes evidence-based clinical algorithms for the prevention and control of non-communicable diseases in the context of primary care in resource-limited settings. And what these guidelines do is they provide evidence-based algorithms in a manner that's not disease specific, but cuts across diseases and looks more holistically at shared risk factors. So for example, somebody who has diabetes and is being cared for diabetes would be managed not only in terms of glycemic control, but they would be managed with reducing other risk factors that increase their chances of dying from cardiovascular disease, such as controlling weight, controlling or stopping smoking, as well as managing their blood pressure. The management also emphasizes not just drug treatment, but also counseling and advice related to lifestyle and prevention. So with that global backdrop in mind, let's zoom into the Botswana's context in particular. As many of you might know, Botswana is a country that's middle-income country that of a population of 2 million that's located in Southern Africa. Botswana is middle-income country, and it does have that means it has ability to spend more on health than other countries in the region. That said, it does have and confront some of the challenges that are shared among developing countries, including underdeveloped health information systems, shortages in skilled healthcare professionals, and weak supply chain. Of note as well in Botswana's backdrop is that Botswana was ravaged by the HIV pandemic. And in fact, at one point, the prevalence among adults in Botswana with HIV was the highest in the world. That was in the early 2000s. And the prevalence then was close to 30% of adults with HIV. And in many ways, because of that experience, Botswana, as some have described, has really come from the brink of extinction with regards to HIV. And so I mentioned this because it could be a barrier in terms of introducing new services, new programming, such as for NCDs, but it could also be an opportunity depending on how you frame it or approach it with respect to supporting NCD services. And I'll come back to how we navigated this later on in this discussion. In terms of NCD burden, just like it was being seen in other LMICs and around the world, the burden of NCDs as well as NCD risk factors was alarming and also rising in 2014. And this is data from the National NCD Risk Factor Survey, which was conducted in Botswana in 2014. So we see that that year, cardiac NCDs accounted for, if you look at just the major four, they accounted for about a third of deaths that year in Botswana. And if you add on injuries and other non-communicable conditions, the total proportion of death is close to 1/2 of all deaths in Botswana. When we look at the risk factors, they are at alarming rates, such as smoking at 18% among adults, and also overweight and obesity at 30%, and raised blood pressure at 30% as well among adults. So when the STEP survey was conducted in 2014, and it's around this time in late 2014 that I actually joined Ministry of Health. And it was at this point that the Ministry of Health was seeing these numbers, was concerned, and also in response to the global dialogue around doing something about NCDs. So one of the first things that was asked of me in my role as heading the program was to do something about these concerning numbers from the STEP survey. So what we were really needing to do was to find out what efforts have been made so far with regards to doing something about NCD burden, what the barriers had been that stifled those efforts, and what more needed to be done and could be done going forward. And there were lots of discussions, there were lots of barriers listed, but what we really needed was a guiding conceptual model to help us organize our approach going forward. And we considered several conceptual models, but what we landed on was the EPIS framework, in part because it emphasized implementation in addition to dissemination. It was relevant to the public sector and also was quite accessible in terms of the way it laid out the different elements of the model, the outer and inner context, and also walking through 4 phases, if you will, of consideration, going from exploration to preparation to implementation to sustainment. So in terms of exploration, what we did was a situation analysis of where Botswana was with regards to NCD burden and what had been done nationally to respond to that burden. We started out with local data. So we looked at the STEP survey data and did a secondary analysis. So beyond looking at the risk factors of the prevalence of risk factors, we wanted to find out what is the performance of services that are currently being delivered. So here's an example using hypertension, and we chose hypertension because it is the leading risk factor of NCDs, and it is a leading risk factor for global burden of disease and disability. And what we found is that among people with hypertension who are on treatment, on medications, only 37% were controlled. By that, I mean they had achieved the target blood pressure of less than 140 over 90 millimeters of mercury. And then if you look at all hypertensives, so not just those on medications, that figure of control, percentage of control, is even lower. And that reflects the number of people who are unaware that they have hypertension, or they are diagnosed, but they're not on medications yet. So that was concerning. And we also, to follow up, to interrogate this a little bit more, the suboptimal performance a little bit more, we conducted a facility-based survey at all primary care facilities around the country, where we're asking questions to find out whether the right personnel, equipment, and medicines were available to deliver care in a way that was evidence-based. And reassuringly, what we found was that for the most part, the staffing was okay, medications were present, and the basic equipment like blood pressure machines, etc., were there. What we did find some gaps to highlight was that there were often medication stockouts within class. So there was a need to increase the knowledge as well as some flexibility to enable, if one medicine within a class was stocked out, you could substitute it for another medicine within that class that worked similarly. There was also what was mentioned over and over again by healthcare providers at primary clinics was that while they were quite comfortable with HIV and maternal care, and they received training either in service or before qualifying, there was very little training that was happening for non-communicable diseases. So they did not feel comfortable managing patients with hypertension, prescribing or following up patients who were receiving treatment for NCDs. And as part of the exploration and the situation analysis as well, we conducted multi-stakeholder consultations and interviews. And there we were able to learn more and identify national policies and regulations and initiatives that could support reducing the burden of NCDs in the country. And examples of these are the Control of Smoking Act of 2004, the National Nutrition Strategy, the National School Policy. What we did find was that, of course, there were no standardized clinical guidelines for treating NCDs at the primary care level or at any level for that matter. And also there wasn't any, there wasn't any policy instruments that spoke specifically to non-communicable diseases. For example, the nutrition strategy tended to focus on malnutrition and on young children. There wasn't an overarching strategy that spoke to those important components, but also to obesity, also to other risk factors for NCDs, and also covered all ages or all age groups. So there was a gap there as well. So with these insights from the exploration phase, we were able to then go on to the preparation phase, and that involved taking the HUPEN guidelines and looking at them and adapting them to Botswana's local context. There were several adaptations, and this process was long, but I'll highlight some of the approaches that we used. The first is that we embedded the HUPEN guidelines into broader primary care guidelines. And the reason for doing this, as well as calling the guidelines primary care guidelines rather than NCD guidelines, was because it was in alignment with the Ministry of Health's general strategy of transitioning from curative, disease-specific approach to a more holistic, integrated approach that really looked to strengthen primary healthcare platform. And so what that meant is that in addition to having the algorithms that describe how you diagnose and treat diabetes and hypertension and asthma and how you screen for breast cancer, these algorithms were coupled with algorithms for health promotion, as well as how to respond to the common complaints that usually people come with in the primary care setting, such as a headache or vomiting, hence the name primary care guidelines. We also reviewed the National Medications Formulary, as it was important to be able to make sure that the essential medicines listed by WHO for evidence-based care of NCDs were indeed catered for and would be procured as part of the usual processes in the government. And then lastly, we engaged stakeholders across sectors. So that included stakeholders within the health sector, from frontline workers to patients to all others who were relevant. And their input was important in terms of being able to say whether what the guidelines are asking for was feasible and fit the workflow of clinical work at the primary care clinics, but also whether the interval and frequency of visits for a stable patient was feasible for a rural-based patient who has a job and has young children, for example. In addition to engaging those stakeholders within the health sector, we also engaged stakeholders across sectors, so included ministries of education, of transport, of finance, included industry partners, development partners, civil society, and we also engaged and consulted the House of Chiefs. I say this as, again, it was really important to get the multi-sectoral buy-in because the response to NCDs requires going across sectors, and where needed, we slowed down the process of finalizing these clinical guidelines in order to make sure that those stakeholder engagements and the processes they feed into were completed. Some of that multi-stakeholder engagement and consultation was towards developing policy instruments, which I mentioned were a gap. And the two policy instruments that we advocated to be conducted at the same time, along with the clinical guidelines, are the 11th National Development Plan. This was a process that took about 18 months of consultation, but ultimately had solid statement prioritizing NCD prevention and control as part of the National Development Plan. The second policy instrument was the multi-sectoral NCD strategy. And this is something that was based on the World Health Organization's NCD prevention and control global strategy. It again also required, it was a process that was 2 years long in the making, but it was one of the first strategies to be endorsed in the continent, and again was instrumental to really getting all the national prioritization relevant and needed for the clinical guidelines to be in place. The other thing I'd mention in terms of getting buy-in from all the relevant stakeholders and prioritization to make sure that not only are the clinical guidelines endorsed, but they'd be sustained, is leveraging HIV. I mentioned that HIV had ravaged the country 20 years ago, and those deaths and what happened and the impact on the economy as well as day-to-day lives of HIV is something that's still quite vivid in every Motswana's mind, and it was something that's still present in every policymaker as well. So it was important that and as a result, what's happened is that a sizable proportion of the national resources are protected and siloed, if we will, and locked in to HIV. And so that could, in theory, be a hindrance, so that any new initiatives for NCDs or any other clinical areas are under-resourced because most of the resources go towards that. So that could have been a barrier, but what we ended up realizing would be helpful was to reframe the discussions in such a way that we show how resourcing NCDs also helps with the HIV agenda. So, for example, we often talked about the fact that not availing treatment and prevention services for NCDs meant that people living with HIV who had survived HIV death, thanks to the investments by the government, might end up dying early from heart disease because they don't have treatment that's available and known to treat and prevent heart disease. And as a result, you'd end up having life expectancy among people living with HIV still being curtailed, and you would have the gains in health and economy that of addressing HIV being threatened by non-communicable diseases. The other way in which we leveraged HIV is by incorporating NCD coordination of NCD activities into the existing mechanism for coordination for HIV. So the formerly known National Agency AIDS Coordinating Agency, NACA, was remade and incorporated NCD prevention and is now known as NAPA, the National AIDS and Health Promotion Agency, and it sits within the Office of the President to reflect the multi-sectoral scope of it. And then lastly is to say that we also did leverage the limelight, the national stage of HIV. The NCD strategy, the launching of it was delayed so as to allow for completion of the development of the multi-sectoral HIV strategy so that both of those strategies could be launched at the same time. And this is a picture of the president of the country launching this with the acting executive director of UNAIDS, and this was in 2019. In terms of implementation, I'd highlight that once it was evident that the clinical guidelines were going to be endorsed, we started getting to work on planning for what implementation would look like. And what we made sure to do was that the implementation wasn't just simply a distribution of printed guidelines or and a couple of media releases, as would typically happen with established guidelines. So we designed a structured pre and post test evaluated program that was 5 days long for each trainee, where we would cover medical management in various modules, but also complementary skills such as defaulter tracing and monitoring of medication stockouts, things that we thought were critical to actually delivering quality care in the way that was described in the guidelines. We also used the training of trainer methodology, where we identified champions, so individuals who were passionate about the subject matter, also had some notable leadership skills, and we trained them to be trainers as part of the training program. But even when the training ended, they would serve as clinical mentors and advisors to their peers in their respective districts in the future. I'll mention only briefly about sustainment, which is that everything I've mentioned so far really contributes to sustainment. So, for example, having trainers or mentors meant that in the future, there was a pool of knowledgeable champions who would be able to deliver refresher trainings for any new staff that had come in to the clinics since the last training. Of course, the policy instruments of the National Development Plan meant that NCD prevention and control strategies would be prioritized regardless of whether there was a change in administration leadership. In addition to those approaches, we also made sure to define indicators, measures of success of the implementation, and we did so using the RE-AIM framework. So looking not only at the implementation itself and whether the guidelines were implemented in the way that we had envisioned, but also looking at the adoption of the guidelines at facility level, the reach of whether the number of eligible individuals would receive these services, and the efficacy in terms of what the clinical outcomes as a result of the guidelines implementation was. So that's a summary of our approach using the EPIS framework. And if you're interested in reading a little bit more and finding out more details about this, I'd invite you to look at a paper we published on this experience in 2019 in the WHO Bulletin, and the references listed here. And to conclude, I'd say that the takeaways are, we used EPIS to guide our implementation strategies, and it really did help to have a conceptual model to do this and organize your thoughts, because without it, it feels like a laundry list of challenges and barriers that you really can't sift through or figure out where to begin or which ones are most critical to address. Secondly, I'd mention that in addition to thinking about the challenges and barriers to implementation, it is important to also step back and think about what are the opportunities therein. And I cited HIV as an example of such an opportunity. And then lastly, is just to mention and remind that the process of implementation, as much as I've described it in a very linear and neat manner, it is a long process and it is messy. So the seeds of implementation of these clinical guidelines really started in 2013, and the efforts kind of started and stalled. The guidelines themselves were endorsed in 2016. Implementation concluded in 2019, and we're only now in the process of evaluating the impact of the implementation in 2022. So all this to say, if you happen to be part of an effort that is looking at to implement an intervention, particularly at national scale, take heart, because this process of implementation and getting to the finish line takes collective action, it takes creativity, but most importantly, it does take perseverance. And finally, I'd just like to acknowledge everybody who has been instrumental to this effort in the Botswana Ministry of Health, at World WHO offices in Botswana, as well as Botswana Harvard Partnership. Thank you.